Even Shobha Gudi ma'am, she told it is.
Probably madam is out of station.
Yes, sir.
Sir, it might be in photo shoot, sir.
Yes, sir. Yes, sir.
Sir.
Okay. So without wasting much time, because some of them have joined, now we will start ahead with our program. At the very onset, I welcome all the members who have logged in. We bring greetings from the imaging committee of KSOGA, and I take this opportunity to seek blessings from my elders, the patrons of KSOGA, and the president, Dr. Durgadas sir, the secretary, Shobha Gudi ma'am, and all the dignitaries of KSOGA who Sir, namaste, sir.
Sir has joined, sir.
Namaste, sir. Sir, unmute, sir. Please unmute. Yes, sir.
Sorry, Raju, late. I was in operation theater, just coming out of the operation theater. Just for your sake, I came running.
Sir,
I'm
thank
very
you.
sorry for joining late.
Sir, no,
No,
sir.
sir, on
Okay.
time, sir. On
On
time.
time, sir. Thank you so much, sir. Thank you so much for being out there, sir. We seek your blessings for this program, the fourth session of our imaging committee. Sir, we will be moving ahead with our second part, which we were discussing on the Mullerian anomalies, sir. So, before we begin, I would request Arun to start the program with the prayer, as we always do. Thank you.
कल्याणम् आरोग्यं धनसम्पदः शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तु ते दीपज्योतिर्नमोऽस्तु ते शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः.
Thank you. Sir, I will start sharing my screen now. Is it seen, sir? Arun?
Yes, sir. Make it slideshow, sir.
Yes, sir. Okay, so this is in the last session we discussed a lot, especially the basics ones. I would like to stress them again. The most important of all the Mullerian anomalies and which you always encounter, most of the times we encounter is the septate uterus, and also because it is one of the entity among the Mullerian anomalies which is having a lot of fertility issues. So we try to cover the most basic aspect of septate uterus as well as the bicornate uterus. We wanted to know the differentiation between that. So this chart was what I played last, which I showed in the last session. So what was I was trying to tell you? There are many classifications. You can follow any one of the classifications, and if you want to report accordingly, you mention by according to this classification, it is being a septate or a bicorporeal or a bicornate uterus. So because septate uterus is quantified so much and lot of research has been going on, and also its implications on fertility aspects is really high. So they are trying to bring out a uniform criteria, but still there is no uniform consensus yet, because the Americans follow their method, Europeans follow their method, and you also have something called as the ACUM. This we introduced in the last session. It was in 2018. So I want to stress it again so that we'll not get confused again. See, Esre wants to divide us based on the proportions. Esre, this is the wall thickness and this is the indentation depth. So they told if the wall thickness, if the indentation depth is more than 50% of wall thickness, then it is septate entity. That is to say, if it is 1 centimeter, this has to be at least 5 mm. Okay. Whereas ASRM has got updated in 2021. So they have made it depth of 1 centimeter now instead of 1.5. Whereas, but the angle they have kept it at still 90°. It is actually, they have to correct it, because we have seen that even more than 100, 130 also we get septate uterus entities that I have shown you in the last class. So what we are trying to tell you here is that ACUM has tried to bring out the pitfalls of both this classification. It has tried to bring out a better one. I don't say it's a better, but it is they are trying to bring out the pitfalls as what they say. So they have kept it at 1 centimeters, which ASRM has copied the same in recent. They kept it at 1 centimeter, but they have not only included only 1 centimeter depth, they have also gone for the depth also. They have also gone for depth, the angle they have increased from 90 to 140 degree, and the indentation to wall thickness. This is what the X-ray people are following. So they have made, if this wall thickness, you are able to appreciate my pen there, the writing, wall thickness, if it is 1 centimeter, they say the indentation depth has to be more than 110 percentile. That means it has to be 11 mm. For example, if the wall thickness is 5 mm, this 6 mm indentation depth is also a septate entity. So this is all about septate uterus. We try to see so many examples. Now, arcuate uterus is no more, they are removing out this terminology, because now ASRM has telling arcuate is nothing but normal. Arcuate is nothing but normal. So it is slowly losing its grip as saying to be told as arcuate. Arcuate, you call it as normal because you have the indentation depth of 1 centimeter, less than 1 centimeter, you take it as normal. So we showed many examples like this, whether it is septate or a normal uterus. I also try to show a good 3D will always try to show these, a good 3D will always try to show the, okay, 1 second. A good 3D will always try to show the cornal edges here. The cornal edges that you are able to see, the interstitial part of the fallopian tube, if it is seen in the 3D coronal plane, then it is a good image. So that is to differentiate between arcuate and a septate. But you are not always lucky to get a septate uterus like this. In this, you don't have any confusion. It is a very deep-seated indentation depth. This was the last slide that I had played in the last session. So we'll move ahead. Today, I know some of you would have been asking why you have not told about the classifications. So today I am not here to confuse you people or bring you a lot of stress by giving you this classification, which is very much easily available in net. And today, this day is the era of phones or AI. See, it's not possible for everybody to remember all this classification, what is U, C and all. But to make it very simplified, what I'm trying to show you is this is the X-ray classification. Here you are able to see that X-ray has made differentiation between the uterus. They kept it as U, cervix as C and V as vagina. So in that they have made the types as U1, U2, E3 and all. So in that you have the septate as U2. So you don't only look into the corpus, you also should look into the cervix, because most of the times you may get a complete septate but a normal cervix. Up to the internal os, it is a complete septate. But after that, if there is a septate entity within that, you have to choose whether it is a septate cervix or sometimes a bifid cervix or a double normal cervix. This we have seen in the last class. So whatever entity you are able to get, whether for unicornuate they call it as hemiuterus. So whether it is associated with a rudimentary horn or with or without rudimentary horn, communicating or non-communicating. Again, they want to look at the cervix and the vagina. So ultimately, they have made this as uterus, cervix and vagina separate entity. Based on whatever entity is showing what problem, you fix it and try to number this. And apart from that, you always try to draw a diagram. They have told, X-ray were the first people to tell that you have to draw a diagram. They have given a column here that you have to draw a diagram when you give the report. And also one important thing I want to tell you about X-ray is that they were the first people to bring out this T-shaped uterus. They did not quantify, but they were the first people to tell about T-shaped uterus. That is a very important entity which we will be touching today. So what about ASRM? ASRM got updated in 2021. So you are able to appreciate, so you cannot remember all these things. You cannot read. It's very difficult, no? So what they have, see, this is an era where you have gotten, when your 2D is good and you have a hint that this uterus is looking like this, then you go and look for the chart, because you can easily download this. You get it on your phone. Sometimes even the machine has got incorporated these images. The machine itself will tell you what is the classification according to ASRM and what you have to do. So important thing about ASRM is that they have included many complex anomalies nowadays. They have included like the ovira. They have included the bicorporeal septate entity as well, which was told by the X-ray people for the first time. You have a septate entity and also a serosal indentation of more than 1 centimeter, that is bicorporeal entity. So we also they have also included Robert's uterus. They have included many vaginal partial septa. Sometimes they also included the cervical or isthmic agenesis. These cases are rare, but we have seen in our center where we have got cases of 2 or 3 cases of isthmic agenesis. So that is how it is. So I would request you to look into this clip and try to tell me what is that I'm trying to show you. If you see, I'm going towards the left side here. I have taken my sagittal towards the left. As I come back to the middle, I come back to the middle slowly. This is in the mid sagittal plane. This is in the mid sagittal. As I go towards the right side, I'm not able to see the endometrial lining at all. So what is the hint that you people might be getting by looking at this uterus? Now, if I take the transverse sweep, you see the endometrial lining is getting deviated towards one side and it is maintaining as a tubular fashion even at the level of fundus. It is not getting splayed at the level of fundus, which usually we see in a normal uterus. So this itself is telling us there is some kind of axis deviation. There is some kind of axis deviation in this. So you are able to appreciate that the uterus is showing, 1 second. I'll play this again. The uterus is got axis deviated, whereas when I go towards the left side, the left ovary was seen very closely in the vicinity. When I came to the right side, I was losing the endometrial lining, and also I was not able to see the ovary very easily on the right side. And when I was taking the transverse sweep, this transverse sweep was showing that the endometrial lining is getting deviated towards one side, and also it is maintaining its tubular fashion even at the level of fundus. And also, when you're trying to do this, you are able to see that you are maneuvering a lot at the vagina. You are maneuvering a lot to get the uterus in mid-sag. So this is the first hint that you will be able to get that it is some problem with this uterus. And some of you would have really got the answer by now. That's what I'm trying to show you. This is a unicornuate uterus. When I try to do a 3D, you will get this. The same case, I'll try to show this 3D. What was there? This was a case of previous LSAs. So you have the scar area as well. It has got deviated to the left side. It is a left-sided unicornuate uterus, a banana-shaped uterus. So what was happening here? One more hint I will try to tell you. Whenever you are doing a 2D, let me tell you, when you have to maneuver a lot to get this uterine axis in mid-sagittal or the parasagittal, you will be able to see that the ovary, whichever side the uterus has got deviated, is very close to that. In this case also, the left ovary is very close here, whereas the right ovary is very far away, as if it has got detached. So this is one of the hint to show that unicornuate uterus, you have these hints in 2D. And most importantly, unicornuate uterus, we gynecologists actually only look at the Mullerian anomaly and come out. We have to actually look for the kidneys. See, maternal kidney has to be seen, that we have trained ourselves, because unicornuate uterus are more commonly associated with renal associated anomalies. So you have to definitely look for the renal anomalies in case of a unicornuate uterus. So what about the fertility aspects? Unicornuate uterus, if the volume of the endometrial cavity is good and the total volume of the uterus is good, they usually don't have any fertility issues. In this case, she's already a case. She has got pregnant, and it was another reason she had come over here, and we could see that she had a very good term pregnancy outcome with a cesarean. So unicornuate uterus, yes, looks banana shaped. Sometimes there might be pitfalls in your 3D, but always look for a 2D before confirming a unicornuate uterus. Why? Because when the axis deviated uterus is there, in 2D you might get a very good triangular shaped fundus at the level of fundus, but in 3D you are able to get this. So those are some pitfalls. You have to actually play with 2D better than later 3D. 3D is for just beautification majority of the times. Yet another case to show you. In this case, the uterus, I'm straight away going to the transverse sweep. This is on to the left. Here at the level of fundus, it is not getting splayed, whereas the left ovary is very in close approximation to the left horn of the uterus. When I come back and look at here, what is that you are able to see? Another horn of uterus. This is the right ovary. This is another right horn, which is not communicating to the lower part, that is the cervical part. So what you are able to see here, I'll try to show at the bookmark. This is the normal cavity which is extending up to from the cervix to the fundus, whereas this a cavitatory lesion which is having an endometrial lining with small collection within it, this echo is in comparison to with this echo. The myometrial echoes of this is equal to this, but this is not communicating to the lower part. This is actually a case of unicornuate uterus with a non-communicating horn. So when you get it, because if you don't span your 2D, if you don't do good spans of your 2D, you will not be able to appreciate the adnexa. So that is the reason why when I get a 3D here, you will be able to appreciate that this is actually a left unicornuate uterus with a non-communicating horn. There is some endometrial activity over here. There is minimal collection in this. So what is the treatment? You have to excise it. I'll try to show you one video of a case of unicornuate uterus with a rudimentary horn. You are able to appreciate when you do a hysteroscope, what is the finding that you get? This is the cervical crypt. This is Dr. Jayaprakash Patil sir here, who's doing the hysteroscope, and you are able to appreciate when I pass the internal os, when we enter into the corpus, you are able to appreciate there is axis deviation of the uterine corpus, and you are able to appreciate only one ostia. So this is getting deviated towards the left. So this is not the medial wall, this is the lateral wall. Whereas this is the medial wall, you are able to appreciate that there is no, there is only single ostia and it is tubular in fashion. This itself is going to tell you that it is likely definitely a Mullerian anomaly. A 3D had showed it is a unicornuate uterus. This is the left unicornuate uterus with the tube and the ovary. You are able to appreciate a large kind of hydrosalpinx and the non-communicating right side rudimentary horn. So this has to be excised. So that is the importance of showing the importance of doing a span. Here is a 14-year-old girl who presented with history of severe dysmenorrhea. And when because of the limitations of TVS here, I've done a TAS to show you. This is the sagittal plane of the uterus. You are able to appreciate the thin endometrial lining, the myometrial echoes, but I'm trying to show you in my sagittal, I was not able to get much information, whereas in the right side, what do you think this lesion would have been? She presented with history of severe dysmenorrhea. So I would ask some of you, what would be the lesion here onto the right side? See, you are able to appreciate the left ovary. So today, because I'm dealing with Mullerian anomalies, maybe definitely would have told it as a unicornuate uterus with the non-communicating rudimentary horn. Yes, but what is important I'm trying to tell you is that if only with history, if she would have come, we would have taken this with the confusion that this is a case of chocolate cyst of the right ovary. The important here is to show that we need to do good span of the adnexa, that you have to really look out for the right ovary. Actually, this is not the chocolate cyst of the ovary. Say you are able to appreciate the right ovary which is appearing now. So the right ovary is behind and below that. So what is this lesion? Is a non-communicating uterine horn, whereas this is a unicornuate uterus. That you would have appreciated because it is not getting splayed at the level of fundus. So this is the left ovary. So this is the right non-communicating horn. What are the differentiating features from an endometrioma? Look here, I will try to show you because this myometrial wall echo is in comparison to the thick wall of the cyst. So usually you don't find so much thick endometrioma. So you are able to appreciate, though the internal echoes are of low intensity as you see in a chocolate cyst, but this thick wall is going to tell us that this is very likely to be a unicornuate uterus with a non-communicating rudimentary horn. So TAS 3D also will help define this. So you're able to appreciate here that it was a non-communicating rudimentary horn. So unicornuate uterus, yes, axis deviated uterus, you have to keep looking at those such things and always span across your adnexa to look for the non-communicating or very rarely a communicating horn. So this was the same case we operated. This is on the right side, which was non-communicating. The same girl, she had severe dysmenorrhea. So this is the left uterine corpus, which is communicating to the cervix. A non-communicating rudimentary horn on the right side, which has to be excised. The treatment of choice would be to excision of this non-communicating rudimentary horn and associated pathologies, if any are there. Like usually they will be associated with endometriosis in the later age group. In this girl, it was clean enough. The peritoneum and the pelvis was clean enough. So we had to excise only the rudimentary horn on the right side, and eventually that was the treatment that was done. So I would request everybody to watch this clip and try to tell me this. Here is a lady who has had almost 1 or 2 first trimester abortions, early pregnancy abortions, and in my 2D I am able to appreciate this picture. What do you think this lady is having? You are able to appreciate in the mid-size thin triple line. She is on day 8 of her cycle, whereas in the sagittal plane, that was in the sagittal. Now in the transverse plane, there is small splitting at the level of fundus. Don't worry, it is usually normal at the level of corpus, at the level of the fundus. Small split, and as I go towards the cervix, this is the picture I'm trying to show you in 2D. So I keep repeating this again and again. See, this is the sagittal sweep. I do the transverse sweep. And when I do the transverse sweep and I go from cervix to the fundus, you are able to appreciate that the endometrial lining is showing some pathology within. Now I'll give you some hint. If at all you can catch that, you are able to appreciate. I'm trying to measure at the middle corpus some measurements of the lateral wall breadth of the endometrial cavity. So it was less, it was very less. It was actually, how many of you have got it? I don't know. But the answer here, I don't, if I can read out, if anybody had typed, no, nobody has typed yet. Okay, I will give you why, because this is yes, somebody has typed the answer. It's very right. It's also Ashish sir. Okay, it's a T-shaped uterus. That is what I'm trying to tell you. This is one of the commonest entities apart from septate uterus we actually are looking into. So the same case when we did a 3D, this is what I get. Look here, the morphology of the uterine corpus is showing a T-shaped uterus. The deep-seated cornua, small indentation depth, which is normal. Actually, you can call it as arcuate, that is not needed here. Look at the morphology. It is tubular in fashion. It is very thin, whereas the deep-seated cornua over here, and this is a case of T-shaped uterus. So today I want to stress a lot on this entity because we need to quantify this so that we are going to tell the surgeon what are the dimensions and how better we can make this cavity a bit normal. I'll try to show you some more cases. Okay, this is how a T-shaped uterus, when we look into the hysteroscopic view, you are able to appreciate that you will not be able to appreciate the ostia when you are at the level of internal os. With the hysteroscope you should be able to appreciate both the ostia in one frame, but here in this case you are not able to appreciate. The lateral walls are getting it is a tubular cavity, and the lateral walls have got converged over here. I will try to show that again here. This is the left side lateral wall. You're not able to see the ostia. It is very deep seated. So, and also you find this concentric ring-like bands on the lateral walls of the endometrial cavity. So these are nothing but the constriction bands that you have in case of a T-shaped uterus. So what is the treatment of choice? The treatment here, when you have given a very good lateral wall thickness, you have to widen the cavity by doing using a resectoscope or Caesar. It depends. I don't want to discuss the surgical aspects and the techniques and the related pros and cons of it, but definitely one of the modality of treatment here is using a cold Caesar. This is Dr. Jayaprakash Patil sir here, to increase the cavity, to widen the cavity so that we need to have a good endometrial cavity volume to give a very good fertility outcome. This was under the, as we keep on cutting the fibers, we will be able to appreciate that once the ostia is getting in picture, yes, that is one of the hint that we are able to see that the cavity on one side, the lateral wall metroplasty, what we call this as metroplasty, is better than now we are able to appreciate that. You are able to appreciate the ostia. So this is what we need to do. You can use scissors on both sides. This is yet another case to show the tubular cavity, and also this was metroplasty was done on both sides to widen the cavity. So this is how we look into T-shaped uterus. This is yet another case to show she had 3 first trimester pregnancy losses. And in my sagittal sweep, you find this uterus to be appearing very, very normal. Okay. Only your 3D, or if you have a very good hint in 2D when you're taking a transverse sweep, if the endometrial lining is not getting widened enough, then you should think always in terms of that whether am I dealing with a T-shaped uterus. See, this is why am I stressing more on this entity is this, because we are actually missing this entity in some fertility problem ladies. And if you have not diagnosed this, and if you have not given a good 3D, we will be able to, we are not only missing this, also our whatever treatment we are giving may be because of the endometrial cavity. And also there are a lot of studies saying that less uterine volume is giving them, not giving them good results with fertility outcome. So I take good adjustments here with my 3D volume on the A plane here, so that my green line is sleeping on the curvature of the endometrial lining, and you are able to appreciate a tubular cavity with a deep seated ostia over here. So this is to show that how a 3D, because a 3D, whenever you are able to get the cornal planes at the level at the ostia, this part is actually what we need to look into 3D. So this is how the same case was looking into 3D. Now I'm trying to show you something very important, because we need to quantify this T-shaped uterus such that whether it fulfills the criteria. ACUM were the first people to quantify this T-shaped uterus. What they have done here, I'm trying to show you with my measurements here. This has to begin from this ostia to this ostia here. I'm sorry for that, but still it was a straight line. So this angle is showing up to 36 degrees. This has to be actually more than 40 degree. This is called the T angle or the cornal angle. One more angle is from one ostia to the indentation, lateral indentation curvature. From there you go down on the endometrial lateral borders. This has to be actually more than 130 degree to say it as normal. Here it has to be more than 40. This lateral indentation angle has to be more than 130. And this is one of the imaginary lines from one cornu, one ostia to the internal os. Do not include the cervix. Do not include the cervix. This is an imaginary line. From there, from exactly the lateral indentation angle point, you draw a perpendicular line to this. When you draw this perpendicular line, that is the that is the lateral indentation depth. This is called the lateral indentation depth. This is going to tell us how much is the myometral wall in this plane. This has to be more than 7 mm. So this is fulfilling the criteria. Here it is 8.9 mm, and this angle is definitely less than 130, and this angle is definitely less than 40 degree. So there are three criteria for that, and this is fulfilling all the three. This is what I was trying to show you. ACUM criteria for T-shaped uterus. One is we saw the lateral indentation angle of 130, whereas the T angle of should be less than, if it is less than 40 degree, and also the lateral wall indentation. See, they have not included the cervix here. It has to be at the level of internal os. How do I make out in 2D there or 3D? You will be able to have some uterosacral parts or the lateral edges of the hindrances. You will see that in some later pictures. That is where you have to draw your imaginary line. Don't take it till here to the lower cervix. There are other methods also. So here is another method by one of the authors, by Alonso and other group. They have made this simplified, where they have taken take the fundus from one ostia to the another ostia. You draw a line, image that is an imaginary line. This line is constant. They take perpendicular line in the mid cavity, almost fixing it at 1 centimeter. So from that 1 centimeter point, you take the lateral wall thickness of the endometrial cavity, and again come down with 1 centimeter. These two are constant, 1 centimeter constant, and look at the lateral wall breadths. What is that I'm trying to show you? Look at the third point. The third point is 9.8, whereas the last is 7.5. What they are trying to tell you is that it is a rule of 10, where rule of 10 is, they are going to tell you that whether it is simplified criteria to tell that it is a narrow cavity. Provided you have ruled out a very good uterine volume, only when you have got a good uterine volume, you should follow this of having a this is simplified method of having a T-shaped uterus. They say at these constants, if the lateral wall depth, lateral wall thickness of the endometrium is less than 10 mm, then definitely it is a case of T-shaped uterus. So this is the same case. We did metroplasty on either sides, because these are the fibers that you see on the lateral walls. This is on the left side. See, even after giving good cuts, you are not able to see the ostia on the left side. So we have to repeat it again to go more deeper depths, because we know that there was good lateral wall thickness of almost 9 mm. So when we went and we tried to resect more, this is on the second. Now we are able to appreciate some the ostia over here. So that is the importance of doing a 3D, and also helping the surgeon, because this one aspect you should be very good enough. I always say that you cannot beat endoscopy, because what you see in endoscopy is something different, you will miss sometimes in USG. But this aspect where if you give a very good lateral wall thickness, the surgeon will come to, because that part the surgeon cannot see. And only when you give a very good diagram or a representation of the volumes or the measurements, they will be able to quantify themselves how lateral I should go and how much of lateral metroplasty I should be doing. So this is the case we did, and this is the volume that we get, the cavity of a normal shape, the same case which we operated. This is the same case, which we got operated. We got a picture like this after 12 weeks. So now she got conceived and she recently delivered, having a term baby. So now what I want to tell you is that in such cases also we will always encounter with, because we have seen that they will be usually associated with cervical insufficiency. Sometimes definitely we always try to put a Shirodkar or interval lap circulage has to be done. We do Shirodkar stitch only after having a good NT and the double marker is showing low risk and no sonological abnormality. Then at 13-14 weeks, we'll go ahead with the Shirodkars. So now they have come up with another very recent one, because T-shaped uterus, dysmorphic uterus is in now limelight like this. Apart from septate uterus, they are doing a lot of work in T-shaped uterus. Now they have come up with a very good one more better criteria. I am trying to stress on this because it on your 2D and 3D is going to play a very important role. One important thing, they have come down with the lateral breadth of 5 mm now, instead of taking it as uh, a 7 mm. See here, from one cornal end to the internal os only. Here, these are some of the echoes you can able to appreciate. These belong to the uterosacals. This is at the level of internal os. The depth, if it is more than 5 mm now, it was 7 mm then, now it is more than 5 mm in this case. In their criteria, they say it is a good lateral wall thickness. And one more important point, they have brought about the ratio between the width of these two ostia, RO, divided by the cavity width at the level of the internal os. So here also, if you have that ratio of more than 5, then definitely it is a case of a narrow cavity. You can definitely widen this cavity so that you can bring out the importance of having a normal cavity. This is a very narrow cavity here. And one more criteria, they have used the rule of 10 that I was trying to tell you. This is a simple criteria where again at the level at the distance of 1 centimeter, you should be having this as less than 1 centimeter. So according to these people, they have told if any of the two are fulfilling, then it is still a T-shaped dysmorphic uterus. So this is the importance I was trying to show more on T-shaped uterus, because this is a very important entity. Now I don't want quantification in such uterus. Definitely this looks like T-shaped uterus. Look at the ostial lining and the upper fundus where they are thin and broad. One important thing I want to tell you, especially in our scenario, if this lady presents with hypomenorrhea, infertility, you have to rule out, when you have a T-shaped uterus like this, you have to rule out COX in India especially. So when you have ruled out COX, you can think that it is a dysmorphic uterus and give the respective treatment for that. Now, what do you think this uterus I'm trying to show you? I'm trying to show you the hysteroscopic view now. I will show you my 3D later. So here in hysteroscope, you are able to appreciate with lot of distension, the cavity is narrow. And what about the ostia? The ostia are very close at the level of just not even deep from this lateral borders. So this is a case where you're able to see a tubular cavity with very narrow cavity, and the ostia are very spaced at a very short distance. The laparoscopy is showing normal morphology. Okay. Now you are able to appreciate, I'll stop this video here. You are able to appreciate this is actually a uterus showing an eye-shaped morphology. Initially, when I did the TVS, I was wrong. I thought it would have been a banana shape, that is the unicornuate. But laparoscopy showed that it was two ostia and uterine morphology counter was normal. So this is a narrow tubular cavity with a very closely spaced ostia. This is a case of eye-shaped uterus. Why am I trying to tell you is that T-shaped is a broader terminology, but nowadays they have come up with subtypes of T-shaped as the classification by the authors who have given the T-shaped only. Now it is T-shaped, I-shaped and Y-shaped. If I would have put this, somebody would have told that this is a case of Y-shaped uterus. But what is that? Because there is a narrow cavity, somebody would have told it is a septate uterus, sorry. But because if you have not have seen that it is a narrow cavity with good lateral wall thickness, it is not falling in criteria of septate uterus. It is actually a Y-shaped uterus. You can read this paper, which is easily available, or T-shaped subtypes. You can type it in YouTube. You have a very good video on this. So yet another case to show you. What do you think of this uterus now? Whether it is a T-shaped uterus? Can anybody tell me whether am I audible and my slides are playing equally good, because I forgot to ask for the reciprocal from your side. Can anybody unmute yourself and tell me is it okay?
Yes, yes, we can hear you.
Yes,
Yes,
sir. Sir, thank you, sir. Thank you, JP sir. You have joined. Thank you, sir. Okay.
Raju,
Now
we can hear you.
Yes, sir. Thank you, sir. So now if I try to show you this, if somebody sends you across a 3D, Raju sir, or somebody, like whether it is a T-shaped uterus, I have made some measurements over here. See, that is the reason why a 2D plays a very important role for your for initial diagnosis and later 3D. What I'm trying to tell you is that in this case, if I try to play the video, I'll try to show the 2D. Why it is not? Okay. Though the measurements and criteria are falling for a T-shaped uterus, look at the morphology. It is appearing normal, but what is the length of the uterus? It is just less than 6 centimeter, and total volume of the uterus is falling below 25 cc. So there are a lot of literature saying that anything less than 6.5, as the international authors, they have many authors have got the papers, but for our population it may not be fitting. But definitely the length of uterus, if it is less than 6, you have to think whether am I dealing with a hypoplastic uterus. And when the uterine volume is itself less than 25 cc, you should actually think in terms of a hypoplastic uterus. It is not actually a T-shaped uterus. So this is what I was trying to show you. And also look here, the lateral wall thickness in this here is very, very less. It's just 11 mm and 13 mm, whereas in a normal T-shaped uterus, it goes beyond 15 or 16. So this, if you give this information to the surgeon, yeah, because we don't want to do unnecessary metroplasty on the lateral side and harm more than this, harm more to that uterus. Yes, you have other modalities like giving them estrogen, progesterone, and improving that. So this is one of the papers that was shared to me by Dr. Alonso when I sent him across my first T-shaped 3D image to him. The first question he asked, what is the volume of the uterus? What is the dimension? Then I made a mistake saying that I did send him the volume of my uterus, and he told you should always differentiate a hypoplastic uterus as well as a normal uterus. So if I take a 3D here, look at this is a very infantile uterus. The 3D of this is itself is showing a narrow, a T-shaped cavity. So this is what we need to understand. If you have, whether am I dealing with a T-shaped or a hypoplastic uterus or a T-shaped uterus. Look here. This lady presented to us in November 2023. It is loss of the information here. This is a very small uterine bud. This lady who presented to us in very small uterine bud, look at the length of the uterus is just 2.2 centimeters. And the height, this is a very small uterine bud. Similarly, another case, you are able to appreciate the total length of the uterus. Though I'm looking at the full screen, it is just 3.5 centimeter, and 3.5 plus 1.7 is less than 5.5 centimeters. These are, if you do a 3D for such case, it will show a T-shaped uterus. You should be cautious in giving treatment. I want to take up that same case which I was trying to show you when she presented to us in 2023, and just by giving her hormonal treatments by cyclical estrogen and progesterone, when she presented to us within 6 months, I'll try to show you that very narrow uterine bud, and the volume of uterus was very less. And when she presented to us after 6 months of cyclical estrogen and progesterone, the same patient, I have taken from the software because I don't want to miss the information, the same patient's ID. So this is what I got. It's almost reaching 4.9 centimeters now. So this lady again presented recently, and it has reached up to 5.5 centimeters, though the uterine volume is less, but definitely she is having a very good outcome with her menstruation. And also she is doing well with her menstruation. This is how we need to sometimes quantify ourselves, and based on that we can definitely improve the by estrogen, the hormonal treatments, we can improve the volume of the uterus. This is a case, very interesting case. If anybody would like to take up, here I'm trying to show you a retroverted uterus, which is showing an endometrial cavity lining, which is in continuity on one side from the cervix to the fundus. When I move towards the other side onto the left side, you are able to appreciate a cavitatory small lesion. I will try to show that again. This is on the right side, a complete cavity from the cervix to the fundus. So it is in continuity. When I move my probe towards the left side, you are able, I'll just come to that a bit here. So I don't want to miss the information. When I take the transverse sweep, you are able to appreciate a cavitatory lesion is seen onto the left side with some collections, very mild. But this is not going down. See, when I take my probe towards the cervix, it is not taking any echoes. It is just limited cavitatory lesion in one side, well within the uterine corpus. So if anybody wants to take up what is this answer, I will try to repeat it again. See, an endometrial cavity lining, it is maintaining its tubular fashion on one side, a small cavitatory lesion at the level of fundus, which is a smaller one, but well within this uterine corpus. It is not outside, like to say non-communicating rudimentary horn. I hope you people got it. If anybody would have answered this, I will try to see. Somebody has answered it as Ashish sir is always right, but I request you to type it later because Geeta has answered it as ACUM. Yes, it's a very close differential for ACUM. But let me tell you, this is a learning which I got from laparoscopy. It is a retrospective learning from me. So this case was actually a case of, I'll try to explain this picture before I come to the diagnosis. See, the endometrial cavity lining was communicating to the cervix to the external lobe on one side, onto the right side. The fundus lining, though there is small dip, don't consider this. This is well within the uterine cavity, a non-cavitatory lesion with the septa in between. So this is a non-communicating septate uterus entity. So this is to be told as a Robert's uterus, as what Ashish has mentioned it. So this was actually a learning for me where it was a retrospective learning. So we need to give a good diagram. So here you are able to appreciate that, when we entered above the internal os, only one ostia was seen. That was on the right side. So the other ostia was not seen. Then we thought it was actually an unicornuate uterus. Then JP sir called me to the OT. No, you come over here because laparoscopy showed a normal morphological uterus, a normal morphological uterus. So it was an intra-op diagnosis by sir that it is a non-communicating rudimentary horn. So then post rendering of the 3D showed me that it was a non-communicating small cavitatory lesion well within the uterine corpus. So it was on this side, which was non-communicating. So we did a communicating surgery for that with metroplasty on the wall, which was not communicating, and we tried to communicate that. So that is about Robert's uterus. Here is another good case from my dear friend, that is Ashish from Jaipur. It is different Ashish who is answering, but he's not that Ashish. He's from Jaipur. So he has a very good case to show. See, this cavity lining on the right side is very much communicating to the cervix, whereas onto the left, it is losing its information as he is going towards the cervix. But look at the serosal borders. The serosal borders are maintaining their integrity, and there is a kind of a myometral wall which is seen in between these echoes that you see. So this is a case of Robert's uterus. So again, these are non-communicating septate entity. So I always keep telling you, the most important thing that we need to look in 3D is always look at the roof of the house. This is the serosa, which I call the roof of the house. If it is maintaining its integrity, and just you have to need to define the endometrial cavity linings, and based on that, your diagnosis has to be. So now ASRM has included this entity, a non-communicating septate uterus. Non-communicating septate uterus, the serosal borders are maintaining their integrity. So this is a Robert's uterus. So there are three types: with hematometra, without hematometra. There is some theory called as theory of apoptosis in this, because eventually when the endometrial glands are not functioning properly, they might go for apoptosis. That is one of the reasons that we don't get hematometra in all cases. Very small hematometra in some cases. Sometimes these girls will present very soon, maybe after their fourth or fifth menarche periods. They might have a very large collection, and that is how we diagnose and try to communicate those non-communicating horn with the surgical aspect where you can communicate that. So here yet another case to show a 16-year-old girl presented with history of severe dysmenorrhea. Sorry, I came to the next slide. So in my transabdominal transabdominal sweep, you are able to appreciate the endometrial cavity lining is showing continuity till the fundus. Where I moved my probe onto the right side, a cavitatory lesion was seen in the myometrial mantle, which is showing low intensity echoes within. And when I come towards the fundus in my transverse sweep, the fundus is actually getting splayed at the level of the endometrial lining is getting splayed at the level of fundus as if it is reaching on both the cornua. So this is a normal triangular split, or not split, expansion of the endometrial cavity. So this is telling me that the morphology of the endometrial cavity is maintaining its integrity here, reaching up to both the ostia, but the cavitatory lesion is isolated and it is well suited within the myometrial wall, and it was seen more lateral and anterior and at the level of fundus. So this is a classical description to show that this is a case of accessory cavitatory uterine malformation. And also to tell you, the cavitatory uterine malformation will have something a hematometra within, as if you see in a chocolate cyst. So it is like nothing but a chocolate cyst, but within the endometrial, within the uterine corpus. So you're able to appreciate here, in this case, that when we have mapped on which side it is, here it is vasopressin that is given, and just below and anterior to the lateral attachments, especially the round ligament. That is what with the cold scissors, we are able to appreciate. We go deeper into this plane. The embryology itself, it's telling us that this is nothing but a gubernaculum defect, and you have classical location for this only at the level of round ligament, near to the round ligament attachment and anterior and fundal. The endometrial cavity lining will be normal. So once we have evacuated the lesion, which are showing the chocolate material that was appreciated, and we close this defect. So this is a case of ACUM. So we majority of all are very familiar with this now. That is the reason why I didn't ask the question, because see what is the difference between the previous case and this case. Look here, this is a retroverted uterus. When I come towards one side, you are able to appreciate a cavitatory lesion showing low intensity echoes, as if you look for a chocolate cyst within the endometrial, that is the myometrial plane. Important thing is that you should look for the endometrial linings playing at the level of fundus. See, it is not like a unicornuate uterus which remains tubular, but it is getting splayed. It's getting splayed at the level of fundus. That is the hint to tell you that this is a case of it's a case of ACUM. So 3D, yes, why 3D is showing the lesion more lower down, it's because they are not in the same plane. So these are all pitfalls in 3D. When you have the lesion in one same plane, they will be at the same levels. But when you don't have the lesions in one plane, so that is the reason. So what is the importance of 3D here? 3D will try to tell me that the endometrial cavity, it's maintaining its normal shape, and the lesion is there in the adnexa, in the myometra, not outside the serosal borders. So many cases to show, to make you acquainted with this. Look here, this is onto the one side sweep. I come back to the other side. When I go towards the other side, a cavitatory lesion with a chocolate cyst-like material, which is seen on the other side. So this, if you get at the level of fundus, and if it is anterior, just look for the splaying of the endometrial cavity lining. If the endometrial lining is getting splayed across, then it is likely to be a accessory cavitatory uterine malformation. Look here, this endometrial lining is getting splayed from one corner to another corner, and this lesion is anterior to that. So that is the importance of doing your 2D, and 2D itself is giving you a very good clinch of the diagnosis, and 3D is showing me the proper endometrial cavity, and the serosal borders are well intact with the lesion in the myometrial wall. So you can take the 3D at the level of fundus. This lesion is well within the serosal borders, and there is playing of the fundus at the level of fundus. The endometrial cavity lining is played. This is a chocolate kind of cyst cavitatory lesion in the myometrial wall. Okay, so now if I put up a 3D like this, then what is this lesion? It looks similar for an ACUM. but it is not. If somebody puts only 3D, don't believe it because you ask for 2D. So the same case, if I ask for a 2D, the cavitary lesion, which looks no same like a solidified lesion in 3D, is actually a fibroid which is sitting there at the same place. You have a same typical, it is not showing ground glass echoes. It is a capsulated hypoechoic lesion with a capsular lesion and circumferential uptake of the Dopplers. So this is how we need to define yourself in 2D, then go for 3D and then give your diagnosis. So I have a case of fibroid, the same typical lesion, and also an adenomyoma. 3D is just a later part of it. See, capsular uptake, classical capsular uptake. This is actually a case of fibroid. So uh, these are some of the important cases I wanted to take up. Before I end up, I want to make small revision for all of us because majority of asked us still they ask whether it is a septate or a arcuate or a bicornate. I'll just try to draw the diagrams and please see this. And after that, we'll have a short discussion of what all we have learned in these 2 sessions. What do you think this uterus is? I'll draw that neatly, sorry. This is a normal uterus. Okay. Now, if I draw an entity like this, so it's very simple. Now, if what we need to understand, this is the wall thickness. The line above this is the wall thickness. This is the indentation depth. Okay. If this indentation depth, for simplification for everybody, if it is 1 centimeter, you take it as septate. But always keep looking at the roof of the house. If the roof of the house is maintaining its integrity here, definitely then this is a septate entity. Okay, now I'll go more importance. If it is reaching up to here and again an endometrial cavity is getting bifurcated, whereas the serosal borders are maintaining its integrity, this is still a septate entity. This is actually a partial septate entity. Now this becomes a complete septate entity. Okay, now one more entity. Now we'll go here. The septum is reaching up to the cervix. And now you have a bifurcation of the endometrial cavities and you have a single external os. Still, it is a septate uterus with a septate cervix. Septate cervix. Suppose you have, sorry, I'll come lower down. Suppose you have an entity like this. Two external os. So then this becomes a case of bifid cervix, but still it is a septate entity. Don't confuse this with the didelphys uterus. Many of them take that when you have a 2 well-defined bifid endometrial cavity horns, but without defining yourself, even when it is well defined in your MRI or a 3D, most of us don't look at this border. If these 2 horns are well within this house, roof of the house, it is still a septate entity. So it is a complete septate with a complete, instead of calling it as a complete cervical septa, you can call this as a bifid septa. Okay, now if you have an entity like this, but what is happening here? The serosal border is also getting indentated along with the endometrial borders. So this entity falls. Now you are able to appreciate there is an indentation of the serosa. Now we call this as serosal indentation. This was indentation depth of the endometrium. This is serosal indentation. If this serosal indentation, if it is more than 1 centimeter, then take it as bicorporeal entity or bicornate. Suppose you have an entity where you have a part like this, but you have a small indentation like this. But if this indentation, if it is more than 1 centimeter, it will fall under bicorporeal entity. But what about this? If it is more than 1 centimeter, definitely bicorporeal. But what about this entity? This entity will be falling in septate entity also. So this is a clubbed entity of bicorporeal septate. So if you really want to quantify when you have confusions, what they say is this is the wall thickness. We all know this is wall thickness, right? If the wall thickness is 1 centimeter, this indentation depth of this entity has to be more than 150% of the wall thickness. For example, this is 10 mm, this has to be 15 mm. 15 mm, then only we call it as clubbed entity. If suppose the serosal indentation is very minimal, if it is very minimal, less than 1 centimeter, then you take this as still only a septate entity, don't put it as bicorporeal entity. Because most of the time we have seen when it is a broad based septa, and if the fibers are pulling this down, you will have an indentation when you see it in laparoscopy. But once when the surgeon starts cutting the septa, you will be able to appreciate there is widening of this, or normal, it comes to normal, or it gets opened up. So that is how most of the times we go wrong in telling it as bicorporeal entity. Okay, we will take up one more. I will take up one more last very important thing. Why, if please answer this. What is this entity? There is no much widening of the endometrial cavity, banana shaped. This is a unicornuate uterus. It may have a non-communicating or communicating sometimes. Very rarely you have communicating, but a non-communicating uterine horn. What is this entity? Anybody want to answer this? Always keep following this serosal borders. See, look here, this serosal border is enclosing both the entity. One entity is showing a tubular banana shaped cavity malformation, and another cavitatory lesion which is having small activity or may not be having the activity. Somebody has answered ACUM. I have explained, that is the reason why I took up this graph, because in 3D sometimes you may not answer. See, this is maintaining its tubular cavity. It is not getting splayed at the level of fundus. Correct. It's Robert's uterus. Somebody has answered it right. See, in Robert's uterus, you have a non-communicating septate entity. I will draw this in very simplified manner. Actually, this should have been like this. Okay. What has happened here is only this part has got communicated to the cervix. This part has got stopped itself on this side. But look at the borders. It is maintaining their integrity well within roof of one house. So this part is not communicating. So here you have this as Robert's uterus. You have this as a Robert's uterus. So most of us get confused with ACUM. I'll try to show you what is ACUM. That is the importance I was telling you. In ACUM, you always have a normal triangular splaying of the endometrial lining at the level of fundus. It is actually a normal uterus, okay? But you have off the plane on anterior aspect a cavitatory lesion. A cavitatory lesion at the level of round ligament attachment, just below the level of round ligament attachment and anterior and fundal. A cavitatory lesion showing hematometra or a chocolates kind of material within. So this is ACUM. So this falls ACUM. So this is Roberts. So it's a very common mistake that we try to find. So because the treatment differs here, this is the excision of this lesion is very, very important. That is what is needed instead of no damage, because you can definitely get it confirmed, because always whatever we do, we always get it confirmed in hysteroscope, because in hysteroscope, when we do the hysteroscope, we are very sure that you will see both the ostia. So then this lesion is a non-communicating, this lesion which is a cavitatory lesion. In this case, when you do a hysteroscope, you only see one ostia. So what in Robert's uterus we do is, we do cut, this is actually the septa part. So we do the metroplasty here, and eventually we make a communication with this. We make a communication, we can even cut this. So it might get broadened here or here. So this is how, for example, if you cut this part and you have to widen this cavity, and this is how it is. So these are the smaller things I have shown. T-shaped uterus, I have taken up many examples. Just before naming it as T-shaped, always rule out hypoplastic uterus. Hypoplastic uterus, there are no strict criteria, but they have told me less than 30 cc, but 25 cc is what we take. 25 to 30 is in a border range whether to go for it or not, but definitely below 30 we should be cautious in diagnosing T-shaped uterus. Above 40, 45, yes, it is a T-shaped uterus. I'm speaking about the volume of the uterus. So based on this, this is all about, I have not included the very simpler ones like Mayer Rokitansky, where you don't find the uterine bud at all and very sleek ovaries, because that those things most of us will not miss, and they usually present at early age. And these are the important things that I've tried to show in the sessions, so that we don't go wrong with these entities, which are, don't say they are not uncommon, they are common, but we should not go wrong or make a wrong diagnosis. What is seen, try to define them well in 2D, then only go for 3D. 3D has to be thorough enough, especially for T-shaped uterus, so that you can quantify it better for the surgeon. Thank you. If anybody wants to ask any questions so that I can learn and also an answer, if I know the answer, I will try to answer it now. Thank you.
Raju, JP here.
Sir, namaste, sir. Sir.
Namaste. Raju, very, very good presentation. Fantastic. See,
You,
just want to tell everybody that, if we can do 3D scan, it is great. If we can, Raju has told how to do it in 2D also, that is also great. Imagine you don't have 3D skills, or imagine you don't have this thing. If you are ordering MRI, okay, to
Yes,
diagnose, that is the next best thing.
Yes, sir.
The thing is, when you ask MRI for Mullerian anomaly, you have to tell the radiologist, listen, concentrate more slices only in the pelvis.
Yes,
You
sir.
don't want to see, kidney, liver and all that. It is useless for us.
Yes, sir.
Give good transfers and sagittal planes. You tell him, take more slices and give good images. Don't read the report, read the film.
Yes, sir.
You just put it in the X-ray viewing box.
Yes, sir.
And look at the image. Most of the time, I and Raju, we discuss, somebody refers us as, bicornuate uterus. It is simple septate uterus, complete septum.
Yes, sir. Most of the
So I put the screen, I put the film, I call Raju, Raju, listen here, see. Unfortunately, what happens is, most of the time, you have only one of properly taken, transfer sections. Most of the time, they are useless. They take from the perineum and above up to the kidney, which is absolutely useless. Okay.
Yes.
You can see whether the kidneys are in place or not, whether they are there or not. That is different. But we want to see for Mullerian, ask your radiologist who is doing MRI, more slices into the pelvis. I want more images, both on SAG and trans. Okay?
Yes, sir.
This is for people who are getting MRI done. That's all.
Yes, sir. Yes, sir. Thank you, sir. Thanks for so much of input, sir. That is what following these basic principles of your 2D and 3D will definitely help. One slide I had taken for, because sometimes it's not always easy to get a 3D. So here I'm trying to show you in this case is an axis deviated uterus. You will always not find a good uterus which is showing you in good anteverted or a retroverted fashion. Sometimes a mid positioned uterus, and when you are able to screen here, this endometrial cavity lining is not showing me properly. But when I take my transverse sweep, you find the coronal plane. The coronal plane of the uterus is showing me that there is bifurcation of the endometrial lining, and this is the serosal border. So itself, you are able to get this coronal plane in 2D. So these are some of the difficulties that we sometimes encounter, but you're having a diagnosis with a very good coronal plane itself in 2D. So this is a case of septate uterus. I am using 4D application over here to make the beautification of the lining of the endometrial linings. So the serosal border is over here. The serosal borders are here, the hyperechoic line. So this is a septa, widely bifurcated endometrial. See, I was not getting a proper mid-sag. So this is how, suppose somebody asks me how do I get a 3D in such case? See what I've changed here, this I will take up in one of the 3D classes, where I have removed the view line from the A plane. I have removed the view line from the A plane because that itself was a coronal plane. I have kept that as a rendered plane. So this is a 3D to show how to look for a sometimes you have to play with your 3D planes, or whether it is A, B, or sometimes that is what I wanted to show you, that it's not always easy to get a good sagittal plane and get a good 3D. Thank you, JP sir, for giving your inputs and insights, sir. Thank you so much. Thank you all members for logging in. And these are the two sessions
Hi,
that
Raju.
Namaste, ma'am.
Sorry for
Good evening.
intervening. Dr. Suguna here.
Yes, ma'am. Yes, ma'am. Got you.
Raju, I want to know how you do the 3D for this young girls, unmarried girls, where we get it trans-abdominally. Can you give
Same,
some
ma'am.
tricks?
Tricks is important. See, definitely 3D is very good in our TVS Pro because of high resolution.
Correct.
Now in abdomen, you'll have to depend on our volume probe, but in volume probe you need to have very good bladder, ma'am. That is first thing. Next
Okay.
is you try to keep the angle which we usually it is kept at 50 to 70. The maximum you get it in volume probe in abdomen is around 90. So keep it at maximum, and
Okay.
always increase the image quality to high definition, more than high. That is maximum you have to keep. And with
Again, sagittal only.
Again sagittal only, ma'am. Again sagittal. But
Okay.
if you have a didelphys uterus or a very wide splayed bicornuate uterus, I have a recent case where even in 3D I was not able to get the entirety in the adnexa. So I depend for that case I took with my volume probe in my abdomen, because there you have larger, wider vision, wider aspect with your image depth. But in that case you can go for your transverse sweep, keeping the probe at the level of, we'll take this class, ma'am, tipping in between wherever, because we know 3D starts from one point, comes to the middle, then it goes to the lateral. So
Correct.
you have to place your probe exactly in the middle. In the same way, in transverse plane, you keep it at the level just below when it is getting bifurcated. So then definitely it will take that volume. If you have a widely splayed endometrial cavity linings, transverse plane with the volume probe TAS will give you very good information now.
Okay. Thanks, Raju. Thank you.
And thank you, ma'am. Thank you so much. Thank you. We'll call it a day. Thank you everyone for being out there. Thank you, Arun. Thank you, Durgadas sir. Sir is there or not? I don't know. But thank you, sir. Thanks, everybody. We'll move on to our next session in the next month, and last Thursday maybe. We'll update you. Thank you so much.